and Disease Prevention Research and the USC Norris Cancer Center. And he's the director of USC HEAL, that's Health, Emotion, and Addiction Laboratory. And his research interests include the influence of emotional traits on substance use and other health-related behaviors, drug intoxication and withdrawal, smoking cessation, and the relationship between genetic and psychological risk factors for addiction. And today, Dr. Leventhal will speak about the role that genetics and personality traits play with respect to drug addiction. So we very much look forward to hearing from both of you, and please join me in giving them a warm welcome. And now, Tom McClellan will start us off.
So thank you very much, Sandra. And I thought what I would do is just tell you a little bit about the strategy we're applying. We're using your money, so you'll be interested to know as taxpayers what we have in mind. So, and that is the theme. We're trying to, like you, we're trying to translate the science into something that's relevant, meaningful, useful to people. So let's just give you a quick glimpse of what our strategy is. These are the demand reduction elements of our strategy, and they're pretty easy and not very surprising to figure out. You start with better ways of purchasing and providing prevention. If you can't do that, let's intervene early. Intervention is no secret to you guys. We think intervention is not something that should be left to the very end of the situation where people are in the throes of such terrible problems, but much earlier, and we'll talk about that in a minute. If that doesn't work, let's get real treatment, for God's sake. Let's have the kind of treatment that could really lead to something useful, because we can. There are scientific studies. We have plenty of evidence-based treatments available. We have a particular emphasis on drug-related offenders in the community because there are so many of them, and because they are so expensive and dangerous in society. And the least sexy, but in many ways the most important, is try to build a better management information system. Okay, well, imagine a pyramid. And that pyramid is a very old portrayal of substance use in America. And the reason I'm giving it to you, so you see where you fit and work that you do fits. What it shows is that the great majority of the pyramid, the bottom part there, represents the majority of America. Most Americans don't use at all or use in very small amounts. This country has more teetotalers than any other country. And most people don't know that. That wavy line there with the dots in it, that we're not quite sure where that line belongs, and it's wavy and it's got holes in it because people come back and forth between that. It's when the frequency, the duration, the intensity of your alcohol, opiate, cocaine, methamphetamine use reaches that point, you've begun to use in a harmful manner. And there is a ton of these people. This is called harmful use. It's not a diagnosis. It's not the people you have on your show. These are the guys that always dated your sister, okay? These are your brother-in-law. These are the guys that are driving in front of you on the Hollywood freeway. These are guys that don't think of themselves as substance users at all. They think of themselves as football fans. They drink a six-pack of beer and then get behind the wheel. That is potentially harmful. They smoke marijuana and then don't take their asthma medication, and their asthma gets exacerbated. They don't think of themselves as having a substance use disorder. We're going to talk about why that is. All right. That solid line there, that's where the frequency, duration, intensity of use has reached the point that you get a diagnosis, that you are eligible for treatment, and that is the most serious of the substance use disorders, addiction, okay? Abuse and dependence. And there are round numbers, 23 to 25 million people who meet diagnostic criteria for addiction. We are no longer the most addicted country. You know what the most addicted country is? What do you think? Russia. Russia. Average life expectancy of males in Russia is 55 years of age because of alcohol and opiates and now cocaine. At the very top, and in contrast, in comparison, we all know there's an epidemic in this country of diabetes. There is an epidemic. Well, there's about 24 million people who meet diagnostic criteria for diabetes. So just give you some perspective. You probably didn't even notice it if you're in the back of the room, but that little orange pinnacle there, that represents the number of people who get any kind of treatment at all, anything. About 2.3 to 2.5 million people. So that's really interesting, Tom, but so what? Here's what so what. You are representing a tiny fraction of the people who are in this area. But nobody is doing anything about people in this area. And look at the numbers. The numbers are alarming. And wouldn't it be nice if there were interventions down here where people actually begin the course of their substance use, when that use becomes harmful and the harmful becomes abuse and the abuse becomes, before it becomes addiction. There's another point. I am, you heard Sandra say so, I am an expert in addiction. I have seen all kinds of addicted people. And that's because I have done a lot of work with people in that top of that pyramid. But you know what? I don't know much about substance use disorders because the people in that pyramid are in no way representative of the people down there. And if this country is going to do something about the substance use disorders, no use of wording here, instead of just focusing on addiction, we're going to need policies that will get us in there. Now, many of you, I guess, have traced the people that you've intervened on to where they go for treatment. So let's talk about that. What about treatment in this country? Oh, it's very different from the treatment of any other illness in medicine. First of all, it's the newest form of treatment in medicine. The treatment system in this country was created in the late 60s, early 70s to meet the then emerging heroin problems of returning Vietnam era veterans. Now, it was decided since they were veterans, we can't ignore them, we can't simply incarcerate them. Well, we'll have to do something. Well, we don't want to treat them with us. Let's make a separate treatment system. And so it came to, I'll get to that. And so they made a separate treatment system. And if you've watched any TV, if you watched any movies, you've certainly seen some kind of caricature of the 30-day program. And that, in turn, has spawned. That's the reason so many people that you see in your intervention say, I don't want to go to rehab. I don't want any parts of it. Part of it is the nature of the disorder and the time point at which you're seeing them. But in fact, some of it is the nature of the treatment itself. Okay? Why should you have to force somebody to go into treatment? It's a complicated process and an important question. This question is one I get all the time from Congress people and people in the public at large. Most people do not think anything works for addicted people, the people you showed on your series. And they ask me, do we have anything that works? Is there any kind of science to this? And the answer is, yeah, we got plenty of things. Here, for example, are simply some of the therapies that you guys have already paid for with your tax dollars. Every one of these has manuals that show how to do this. They're all free. They're all able to be learned by people who are therapists, and they are not used by virtually any of the treatment programs to which you send the people you intervene on. You're not going to see them there. And there is the same level of evidence supporting the effectiveness of these as there is for the medicines that you and your children take. 2 randomized controlled trials. But they're not used, you say? Yeah, they're not used. Huh, that's interesting. You keep saying this is medicine, Tom. We got any medications? Yeah, we do. You know about tobacco replacement therapies, nicotine replacement therapies. The new medicine is Chantix or varenicline. Very effective. Quit rates of about 40 to 50% for stay quit for about a year. Much better than anything that's been before. We have medications. I'm happy to go through the individual ones. But the point of this, they're all in green because they're available right now from doctors. If you got an alcohol problem, you can take naltrexone. Your doctor could prescribe you naltrexone or a Camprosate or disulfiram Antabuse for that. And they are not cures, but they are quite effective. And no, I haven't made a mistake. I have naltrexone under opiates and alcohol. And that's because naltrexone is an opiate antagonist. It occupies a receptor and displaces any opiate. So if you're taking naltrexone and you shoot up heroin, you will not feel the heroin. You won't get punished for it or anything. It'd be like shooting water. It's a pharmacologist's dream come true. But the other interesting quality is that if you take the naltrexone and then you say, I think I'll go have a beer, you might not get the same buzz out of that beer that you would normally get. Because part of the reason alcohol feels good is because of what it does in your opiate receptor system. Anyway, point, we've got these medications. In yellow, I have medications that do have a couple of trials that show that they are effective. They're not yet ready. They don't have FDA indications. And yes, vaccines are available. Vaccine that you can take in the last 30 days and will prevent a person who uses cocaine from being able to feel the effects of cocaine if they use it. We ain't got nothing for marijuana yet, and we ain't got nothing for methamphetamine, but there are a lot of studies going on. But here's another important point. If you go to your doctor, you're not going to get any of these, or you're not likely to get any of these. Wait a minute, what's going on here? You can't get any of the appropriate behavioral therapies. Now you can't get any of the Medicaid. What's going on? What's going on is segregation. As I told you, this is the only area of medicine where we have specialty care, all the treatment programs you send your patients to, but no meaningful involvement of primary care. And it's been this way forever. It's because it hasn't, the idea of addiction has not been understood. It's been understood partly as a sin or a bad habit. And you don't want to really give too much emphasis to treatment because, after all, that would be giving permission to get addicted, wouldn't it? That's been the thinking. And so none of the roughly 12,000 treatment programs, by comparison are around 9,000 Starbucks, okay? Well, we've got about 12,000 specialty care treatment programs. None of them are very closely affiliated with any part of medicine. And I'm going to show you why that has importance. A third only treat about 200 patients in a year. How do they even stay alive? Because federal government pays for it. That's how. 2/5 don't have either a doctor or a nurse on staff. Point, remember I just showed you those medications? Who prescribes the medications? If you don't have a doctor, you don't have an electronic health record, you're not part of any area of medicine. 3/4 don't have a psychologist, psychiatric nurse, or social worker with kind of advanced degree training that allows use of those behavioral therapies I put up there. Well, Christ, who's there? Counselors. Counselors are a professional, hardworking, diligent, dedicated group. No PR here, they are. But it's a miserable job. They make not very much money. They don't get much respect, and consequently, the turnover rates are about 50% a year. I usually give these kind of talks at a hotel. That's about the same turnover rate as the people who make the beds